My name is Lauren Stiles. I'm the president and founder of Dysautonomia International. And I am very glad to be joined this evening by Kate Bourne, who is a young POTS researcher at the University of Calgary, but don't be fooled by her age because Kate is really brilliant and has done a lot of really important research in the POTS field already. And I can't wait for her to be Dr. Bourne because I know she's going to do a lot more. So what we're hoping to go over this evening is everything we've published to date on the Big POTS survey, as well as talking about the future of the Big POTS survey and how you can be involved in that, whether you've taken the survey already or not. And then we're also going to cover the impact of this survey to really help everyone understand why it's so important to participate when there are large studies on a disease or diagnosis you might have. And then the last thing we're going to cover is just talking about some other POTS research updates that I think will be of interest to our patient community, because there's certainly a lot going on outside our little survey, which isn't so little. But anyways, all right. So I think we've probably, we're still going to have a couple people joining a little late. We are recording this. So if you get tired and you can't listen to the whole thing, everyone who registered for the free webinar will be emailed a copy of the recording. Give us a week or two to get it formatted, because we usually do a little editing on the beginning and end to add a little music and a logo, but we will email it out to everyone. So with that, I am going to share my screen. Okay. So as I mentioned earlier, I'm joined in this presentation by Kate Bourne, and Kate will join after my slides. I'm on faculty at Stony Brook University School of Medicine. Stony Brook hasn't officially been part of the Big POTS survey because it was started before I was on faculty there. But we do have some other medical students at Stony Brook who have really taken an interest in POTS research, and they are going to be doing some of their own similar type of studies, probably smaller in scale. And so stay tuned for that, because we will be distributing those surveys and other research opportunities on our social media and our email channels. So what are we going to cover? We're going to talk about, what is the Big POTS survey? We'll review the abstracts and manuscripts published to date. We'll talk a little bit about the impact of this work and how you can get involved. And then, as I mentioned, we'll cover some POTS research news and updates. So for those who don't know, I think a lot of people know what this is, but for anyone who's new to this topic, the Big POTS survey is a collaboration between patients and researchers, and I would say and caregivers as well, designed to document the real lived experience of people with POTS. So often research is designed by, very formal academic types, and they're assessing things that are important for research, like heart rate variability or the tachycardia, right? But it isn't necessarily like everything that's important to patients. So we were very, very lucky. When I first started Dysautonomia International, the very first conversation I had with Dr. Raj, who I was super excited to talk to because he's a bit of a POTS research rock star. This was back in 2012. And our very first phone call, I said, hey, we have, I think maybe at the time we had like 2,000 people following us on social media, which was a lot back then. And I said, we should do a big online POTS survey and ask those patients some questions, And so that's how this study was born. And Dr. Raj was very collaborative and very interested in making sure that patient voice was represented in designing the survey and what questions and topics we asked about. We beta tested the survey with Dysautonomia International's Patient Advisory Board and got their feedback. Several caregivers giving feedback, particularly caregivers of pediatric patients. And so the survey is English language, and it's open to anyone in the world who has been diagnosed with POTS by a medical professional. It's open to people under age 18, so long as we just ask that their parents take it with them so that we have an adult help filling out the survey. And so far, we have about 10,000 people enrolled to date, and it's people from over 15 different countries. The vast majority of people are from the US. I think the second most common country was Canada. But even with the different numbers of people in the US and Canada taking it, we can actually compare the lived experience of people with POTS in different countries. And I think Kate might actually have some US versus Canada data for us later in terms of diagnostic delay and that kind of experience. So it was started with Dysautonomia International and Vanderbilt University, but eventually Dr. Raj moved to the University of Calgary. He was originally Canadian, so he was kind of moving back home. And he brought the study with him. And that's how we were blessed to have Kate and other students that are working with Dr. Raj to get involved and even do more with the survey. So we had a pretty broad range of question topics, right? A lot of times online surveys are really short. It's 10 questions. And when the patients were giving feedback on what the survey should include, initially some of the Vanderbilt folks were like, oh my gosh, this question list is way too long, right? But we knew that if we asked about things that really mattered to patients, that patients would want to tell their stories, particularly people with POTS who have been kind of ignored by the medical system. And sure enough, we had a very high completion rate on the survey design once it was spread out to the broader community. So each of these different topics we've asked about could actually end up being its own manuscript in terms of journal articles. I want to mention that there has been no funding for any of this work, right? Just Dr. Raj and Kate and other people involved in the study have not been paid. Everyone is doing this literally out of the goodness of their heart because they care about the POTS community. And so I'm very grateful to all of them for being involved. And I'm also grateful to all of the patients and caregivers who spent the time to tell us their stories in the survey. So this was our first manuscript. This is digging way back, right? And so the way research publishing works is you capture data in your study, and then usually you summarize the early results and you present it at an academic conference. And that actually accomplishes a few things. First, it sort of lets people know that you're doing some new research, and it kind of gives a sneak peek to the data. But it also helps raise awareness about POTS because, as we all know, many medical professionals have never really heard of it, or they're not terribly interested in it. They think that it's rare, or that, which it's not, right? They think it's rare, or they think that these patients are difficult. I don't want to see these patients. And I think it's really just due to a lack of training and a lack of understanding on what it is. So each time we present one of these abstracts or conference posters or oral presentations at an academic medical conference, we're actually training doctors on POTS and teaching them that it's real and that it's treatable and that they should take the time to learn how to treat it and diagnose it. So I'm not going to go super in depth on each of these because I'm going to make my slides available if people want to look at these in more detail. Also, it's really important to remember that when we present an initial conference poster, that's the preliminary data at that time that poster was made. And then sometimes the data slightly changes when you go to publish the full manuscript, because by the time you're publishing the manuscript, you might have 1,000 additional patients in the study. So the numbers, slightly change. So if anyone sees a number here that is a little bit different than what's in the manuscript, don't get angry with me. Just realize that this was prior to some of the manuscripts. So what we thought was kind of interesting is that 9% of people who took our survey were seen at one of the Autonomic Disorders Consortium sites. These are the bigger academic autonomic labs that are very hard to get into. So that tells us that more than 90% of our POTS population is probably not seeing a doctor that has really significant autonomic expertise. And so that's part of the reason why so many of us struggle to get good medical care. There just aren't enough experts to go around. We also found that 35% of patients suggested POTS as a possible diagnosis to their doctor before the doctor made the diagnosis. And we don't really have comparison data on what that looks like in other diseases, but I would guess that it would be a lower percentage. And so I think that speaks to the importance of our organization providing good patient and public education resources so that patients and caregivers can advocate for themselves and say, this is the diagnostic criteria for POTS, and these are the common symptoms. Hey, doctor, do you think I might have this? And we also found that, not surprisingly, 75% of POTS patients researched POTS on the internet I think that was prior to diagnosis. I'm pretty sure 100% researched POTS on the internet after they're diagnosed, for sure. we had many, many patients being misdiagnosed and being told their POTS is just due to psychiatric or psychological problems. But then after diagnosis, only maybe about a third of POTS patients are being treated for anxiety or depression or other psychological problems. And that's actually that's pretty similar to the national average. So if you take a general population of like 100,000 Americans, about a third of them are receiving treatment for anxiety or depression. So it doesn't seem like, while there certainly is chronic illness associated situational depression or anxiety about not being able to get medical care or having your life disrupted by a pretty awful illness, there doesn't seem to be evidence that POTS itself is caused by psychological problems. So this was our very first abstract. We were pretty excited to present this. I think this was from 2016. And then here was the sort of abstract that formed the basis of our first journal article on this paper, on this data. And you can see here this very long list of comorbidities in POTS patients. These are comorbidities, just means other things people are diagnosed with besides their POTS diagnosis. And so we had a lot of migraine, vitamin D deficiency, IBS, Ehlers-Danlos, chronic fatigue. I think that these diagnoses are pretty familiar to anyone who hangs out in our support groups. It's important to note that not every patient is screened for all of these conditions, right? The quality of the workup you get very much differs between doctors and also differs based on your symptom presentations. So what we'd like to do is kind of take this data and make recommendations on, well, since there's so much migraine in the POTS community, maybe every POTS patient should be screened for migraine, because that is a treatable condition. And if you treat your migraine, you might actually see improvement in your POTS symptoms. Same thing with most of these other diagnoses. So another notable thing is less than 10% of patients are diagnosed with small fiber neuropathy, at least reporting that they were diagnosed with it. And we know from multiple other POTS research studies that more than half of POTS patients have small fiber neuropathy. So that means a pretty high percentage of POTS patients are just probably not being screened for this at all. And that makes sense because we have other data from the Big POTS survey showing that the vast majority of POTS patients are diagnosed by cardiologists. And, most cardiologists don't think about neuropathy. So that just shows us something that we need to do clinician and patient education on the role of small fiber neuropathy, how it's diagnosed, and how it can be treated. Let's see, what are the other highlights from this? The age of symptom onset, we thought that was pretty important. So the majority of people, it's roughly divided in half actually, between patients getting diagnosed before age 19 and patients being diagnosed after age 19, which we would consider adulthood. The peak age of onset was age 14, and that is consistent with other studies done in POTS showing that the peak age of onset is like 13 or 14 years old. But there are plenty of people who develop it in adulthood, right? And it's possible that because there's such a stigma that POTS is just there was for a very long time a stigma that POTS is just a pediatric condition. So there are probably a lot of older people who have it who just never got diagnosed. Especially like if you're 50 years old now and you had POTS when you were 11 or 12 or 13, back then you probably just didn't get diagnosed. So we're very interested to see how these numbers change over time as there's increased awareness about POTS and increased clinician education on it. Another thing that we find and consistent throughout the POTS literature is that a very, very large percentage of people being diagnosed with POTS are female and are Caucasian. And so there are definitely things we need to consider when we see such a race differential. It's very likely that barriers to accessing medical care are playing a role in who gets diagnosed and who doesn't. And that's something that we are trying to work on as an organization, improving awareness and recognition in BIPOC communities, improving awareness and recognition in hospital systems that serve minority populations throughout the world, and also trying to support patient advocacy in other countries where white people are not the majority race, because we think that actually good research can come out of other countries where other people are being better served. So for example, there's been some really fascinating research out of Korea showing POTS patients in Korea having genetic markers that associate with autoimmunity. But when we look at who's enrolling in POTS research in the US, we rarely ever see Korean patients. But there's enough people having it in Korea that they're doing pretty good research on it. So we have to work on that issue as a patient community, making sure more people get access to diagnosis and care. So this, as I mentioned earlier, the vast majority of people are being diagnosed by a cardiologist. And so this tells us like what doctors we probably have to work on to do better education. Even the cardiologists, while they are making about 43% of the diagnoses, I think most of us who've seen a cardiologist probably could agree that the average cardiologist needs a little work on how they diagnose and treat POTS. So here's our next abstract we did, and this was fun because this topic had never really been addressed in the POTS research literature before. We are on the support groups with hundreds of thousands of patients now, and we hear people talking about symptoms of sensory neuropathy all the time: burning pain, numbness, tingling, kind of weird itching sensations, which are also controlled by your sensory nerves. So we did some questions on sensory nerve symptoms, right? So a survey can't actually diagnose someone, at least the kind of survey we did, can't actually diagnose someone with sensory neuropathy. But when you see a symptom pattern that aligns with sensory neuropathy, that gives you a hint that we need further clinical research to identify whether these symptoms are actually caused by sensory neuropathy. And since the survey came out, that clinical research did happen, and it was found that POTS patients do in fact have small fiber sensory neuropathy as well as small fiber autonomic neuropathy. So in our study, you can see the overall symptom percentages, but this was sort of, my screen just decided to go a little crooked. These were the percentages of people who had burning, numbness, and tingling in their feet. So you can see it was, over half of patients having at least one of the symptoms of small fiber sensory neuropathy, as well as their hands. And we also had data on symptoms in the face. It doesn't have one of these breakdown charts, but you can see more than 40% of patients report sensory symptoms in their face. So POTS patients might have what's called a non-length dependent small fiber neuropathy. Length dependent is when the small fiber nerves in your toes are the most damaged, and the small fiber nerves closer to your head and your spine are doing better. What we see in a good subset of POTS patients, and this definitely needs more research to kind of parse out the percentages, is a good percent of POTS patients have a small fiber neuropathy that's actually worse in their upper body than in their feet. So a lot of times doctors aren't even thinking to screen for small fiber neuropathy if a patient isn't saying, oh God, I have burning feet, right? So if you don't have burning feet, but you have burning on your face or your scalp or your upper torso or your upper back, that can actually be a non-length dependent small fiber neuropathy. And that's usually what is seen in people who have autoimmune related small fiber neuropathy. So anyways, this survey was sort of the first to document that sensory neuropathic symptoms in POTS. And there has been subsequent clinical research documenting this too. So I'm gonna keep going, otherwise I can talk forever here. So don't mind me if I skip around, but these slides will all be available for anyone who really wants to do a deep dive and read everything. So this was a poster from, I want to say 2017, on the educational and social impacts of POTS. The educational impacts being particularly important because we have a very large number of our patients are school-aged or college-aged people. And so we found that again, we found the peak age of onset was 14, right? So the majority of the people who took this survey were over 18. So that means they had completed at least their primary education by the time they took this survey. And a really substantial percentage, I think it was about 30% of patients had missed more than 100 days of school before completing their formal education. So that is a lot of missed schooling. That can cause problems for students, that can cause you to be left back or need homeschooling or sort of arguing with the school system on what your educational plan will be. So we definitely need more awareness of this amongst school counselors and teachers and school nurses and administrators to help people get the support that they need to finish their education successfully. We also found that modifying your coursework or your schedules was actually really common in POTS, and particularly in the college students. And it's harder, at least there are different laws in different countries, right? But in the US, it is harder to get accommodations at the college level because there aren't the same protections in place as there are for younger children. So particularly if you go to a private university, so this can be challenging. And then we see quite a few percentage of POTS patients who were delaying their enrollment or just dropping out or not completing their higher education, meaning college, was half of POTS patients and not completing or delaying enrollment in college. So that's a really big impact on someone's life if they're not going to get a college degree because of their POTS symptoms. We also found that 25% of POTS patients used homeschooling services. So think about the economic impacts of that to school districts and why school districts should actually have a vested interest in helping these patients get accurately diagnosed and treated earlier. Because like many diseases, if you get diagnosed and treated earlier, you might actually have better long-term outcomes rather than suffering so many years undiagnosed. And so we had a fairly high dropout rate from college of 23% and a little over 7% dropping out of grad school. We had the housing impacts we looked at. About 10% of folks who had moved out from their parents' home had to move back home due to POTS. A third of POTS patients were living with their parents. I believe this was over age 18 patients that we were asking. And 26% of folks said they would not be living with their parents if it wasn't for their POTS symptoms. So that's pretty frustrating. It sort of feels like a delayed of your launch into adulthood if you're forced to kind of live at home due to health issues. And that can put a strain on the family too. So we definitely need more resources to help families cope with that. Relationship impacts, we had just a little more than 20% reporting that they lost a spouse or a significant other partner because of their POTS symptoms. A little bit more than that reported, slightly more than, I think it was 25%, reported that they've lost other family relationships due to their POTS. And sadly, 60% reported loss of a close friend. So that really, to me, emphasizes why our patient support community is so important for each other, right? If your healthy friends don't get it, at least you can make friends with some other POTS folks who are not going to judge you for having POTS and who really understand what you're going through. We've seen 8.3% of people reporting a divorce due to POTS. So, serious health issues can have real strains on marriages. And so we want to do more to educate spouses and partners. We actually have a spouses and significant other support group to help dampen these problems a little bit, to help spouses learn more about it in a sort of compassionate educational setting. And so we think that doctors should be paying attention to this too, right? They shouldn't be just trying to fix your heart rate. They should make sure that you are getting the educational support you need and sort of checking in to see how your family's doing. And there are some times where, counseling can be helpful, not to say, oh, because POTS is psychological, you need counseling. But if your family's going through a lot of strain, sometimes there's different kinds of relationship or marriage counseling that could help. So here's a study that was presented, I think this one is also 2017. There are actually some notable POTS doctors, not on our board, who advocate that we shouldn't even screen for Ehlers-Danlos syndrome. We think this is a horrible position. We do not agree with it, but you need data when you're sort of arguing with doctors over policy and clinical care guidelines. So we did some analysis on our data, and we tried to figure out, does screening for EDS patients matter or not? Is there a difference between POTS with and without EDS? And what we found is, yes, it does matter. People with EDS, interestingly, they seem to have the same rates of the orthostatic symptoms, the lightheadedness and the tachycardia and the syncope, the shortness of breath on standing, right? But EDS patients had higher rates of GI symptoms than non-EDS POTS patients. They had higher rates of the sensory neuropathy symptoms, the burning, numbness, and tingling. And that's not surprising, because there's actually research from Europe showing that Ehlers-Danlos syndrome patients have a higher rate of small fiber neuropathy than overall POTS patients do. So we think it's really important to screen for EDS. And Kate actually, I think, is going to present a little more data later on pregnancy outcomes in EDS, which also suggests the importance of screening for Ehlers-Danlos syndrome in all POTS patients. And I would actually extend that to all dysautonomia patients, because EDS isn't just associated with POTS. So here's another survey result we did. And so I know some patients get a little nervous when they see the word deconditioning in a Dysautonomia International research presentation. But the reality is that many doctors assume they're misinformed, and they assume that POTS is just caused by deconditioning. And it's just that simple. If we just exercise them, they'll all be magically cured. And so those of us who live with this know that that is largely not true. There might be some people who do really dramatically better with exercise. But there are a lot of people who do the exercise and they see some improvement, but they're not magically, magic wand cured. And so anyways, we did this, we just asked patients questions about their exercise habits before they had the POTS diagnosis and after the POTS diagnosis, and what influenced their exercise habits. So before POTS, 65% of patients were exercising at least 45 minutes a day, 3 to 4 times a week. So those patients are definitely not getting POTS due to deconditioning, right? They were not deconditioned. These people were generally young people in good shape before they got sick. Post-POTS diagnosis, surprisingly, about half of POTS patients were still exercising 3 to 4 days per week. So those patients aren't deconditioned. And these 50% of patients that didn't exercise 3 to 4 days a week, some of them are still exercising, but just not to the amount that we had asked about. So the changes in exercise habits due to POTS symptoms, a very large majority of patients had to alter their exercise habits, or they had to stop exercising because of their POTS symptoms. But about 20% kept the same routine they had before POTS. So we also know, we're kind of curious what physicians were telling POTS patients. And thankfully, 72% of patients were not told POTS is just caused by lack of exercise, which is good. Sadly, 27% were told that it was caused by lack of exercise, right? And of those patients who were told, oh, it's just caused by lack of exercise, 67% of those patients were exercising 3 to 4 days a week before they got sick. So that's just not an accurate physician assessment, right? And then we had 40% of POTS patients were told POTS can be cured with exercise. The C word, is a very bold word to claim. I think it is fair, based on the research we have, to say that a majority of POTS patients who can do the exercise do improve on exercise, but very few, I think, would be classified as truly cured. Being cured means you don't need any further treatment. And what we see is when people stop exercising, they often kind of revert to getting more POTS symptoms again. So, and then the exercise advice received, right? So 15% of patients were advised by a physician not to exercise. And about even split of people being told to enroll in a structured exercise program where there's like guidelines and advice and schedule, calendars and schedules and whatnot. But another big chunk of patients was not given that kind of advice. And I think many of us have probably experienced this, where a doctor just says, oh yeah, get some exercise, and they don't really tell you what to do. So that can be kind of confusing for patients, not knowing where to start or how much or when. And we noticed that people who were advised to enroll in a structured exercise program were more likely to be exercising than people who were not given that kind of advice, or people who were advised not to exercise. Interestingly, even of the patients who were told not to exercise by a physician, almost 40% of them were still exercising 3 to 4 days a week. So I think that's patients kind of just maybe not trusting their advice of their doctors. Certainly, this is a topic that needs more research on what is the right type of exercise to do, when to do it, how to do it without causing a big flare or crash, and what does it mean when we add treatments like beta blockers or Mestinon or IV saline? Do these things help us become more active so that we can actually do the exercise? So that's a whole nother line of research that has to happen. Here is an abstract. I didn't have the actual poster. I'm not sure if there was a poster. I think this might have been an oral presentation, but I just threw the text in here, the short version of the text of a text abstract that was presented at an academic conference around 2017, 2018. And of our cohort of patients, 9% were told they had mast cell activation syndrome. So we know from other POTS research papers where there was intentional screening of a large group of POTS patients that the percentage is actually much higher than that. But this is who is getting diagnosed in the general population of POTS patients, who's getting that workup to make the diagnosis is pretty low. So we need to do more clinician education on how to recognize the symptoms of MCAS and how to diagnose it and how to treat it. So we found that EDS patients were more likely to be diagnosed with mast cell activation syndrome. And then the delay from the POTS onset of symptoms was longer in the MCAS patients than the non-MCAS patients. So that could suggest that when you have mast cell activation syndrome, your symptom profile could be confusing for doctors. So maybe they don't diagnose your POTS quick enough, or that a longer diagnostic delay leads to sort of worsening disability and more comorbidities, and that the MCAS is actually maybe in part a consequence of just having really debilitating untreated autonomic dysfunction, since your autonomic nervous system actually regulates your mast cells. And it's not a one-way street. It's a sort of, I wouldn't even say it's bi-directional. It's not really a linear. It's like there's so many overlapping pathways between the immune system and the autonomic system. So that's just an interesting point, that the MCAS patients are taking longer to get diagnosed with POTS. A family history of POTS was more common in the patients who had mast cell. And of course, not surprisingly, the mast cell group reported more skin flushing, hives and around the ankles and feet, and hives around the rest of the body. So we think that, this just sort of hints that we need to have better clinician education, even amongst POTS experts, on how to screen for mast cell activation syndrome and how to diagnose it, and most importantly, how to treat it once you do find it. Okay, I'm going to keep going here. Oop. This was a poster that I did, I think it was around 2018, the American Autonomic Society conference. We looked at family history from our big POTS survey data, and we found that, here's the, just going to do a little zoom in here on the graphs. So we found that 14% of male POTS patients and 11% of female POTS patients had a blood relative diagnosed with POTS. Male patients were more likely to have a relative with POTS that was a sister, a mother, or an aunt. So that was interesting that it was female relatives being diagnosed in the male patients. So in terms of identical twins, not fraternal twins who don't share the same DNA, but identical twins who have the same exact DNA, both twins were diagnosed with POTS in 28% of identical twins. So that is showing that at least in those patients, there is definitely some kind of genetic relationship there that needs to be further studied. If anyone listening is an identical twin, whether you and your twin have both POTS or don't, one of you, the most interesting for researchers is when one twin has POTS, and the other twin doesn't have POTS, then they look at your DNA and see what's different. And that gives a hint as to what genes might be causing POTS in the identical twin that has the symptoms. So if anyone has an identical twin, reach out to Dysautonomia International, because Vanderbilt has been doing a twin study for many years, but it's very hard to find identical twins where someone has POTS. So in terms of people not just having a POTS diagnosis, but being diagnosed in your family with any orthostatic disorder, some other type of dysautonomia, 81% had no relatives with this. 17% had at least one relative who had some kind of autonomic or orthostatic disorder. Most often, it was orthostatic hypotension, which is fairly common in elderly people. We don't know the age of the relatives that had this, but usually it's older folks that have OH. Reflex fainting, which is like vasovagal syncope or neurocardiogenic syncope. 4% had a relative with autonomic failure, and then 32% had sort of other types of autonomic dysfunction. People with EDS were, not surprisingly, more likely to have a relative that was diagnosed with POTS. So that's just the highlights I was going to go through on that. We definitely need more genetic research in POTS to understand, do certain genes increase our risk factors for this? Do certain genes make this more likely to run in our family? So this was the first manuscript we did, and this published in 2019. And this manuscript has been cited over 200 times by other researchers, which is kind of cool. Like just to find out that other researchers are reading it or other clinicians might be reading it and learning about POTS, it feels really good for I think our patient community to have some increasing awareness there. So this study found, similar to other POTS studies, 90% of people diagnosed with POTS are female. The symptom onset was roughly divided between pediatric and adult onset. And the most common symptoms were tachycardia, lightheadedness, difficulty concentrating, which many of us call brain fog, headaches, and presyncope. So 91% of patients have lightheadedness, tachycardia, and presyncope. And 83% of POTS patients have all 5 of these symptoms. And of course, a long list of other symptoms too. These were just the most common symptoms reported. So we looked a little bit at prognosis, right? And I just want to give the disclaimer that our prognosis data is a bit skewed, because if you had POTS when you were younger and you fully recovered, you wouldn't be hanging out on a Facebook support group and taking a survey, right? So it's our survey data is probably biased towards patients who are not recovering, because you're hanging out on Facebook talking to other patients if you're still not doing well. But what we did find is that a majority of patients reported since the time of onset that their symptoms had worsened a lot or a little bit since their onset. About a third reported that their symptoms had improved since onset, and about 8% reported no change. Of the patients who improved, about 30% said it was due to pharmacological treatment, and a majority said that non-pharma treatment helped as well. Also, I did want to highlight the patients seen at the Autonomic Disorders Consortium sites, which are these like specialty autonomic labs. There's only a few of in the whole country, or in the whole world, I should say. Those patients were more likely to improve compared to people who were seen elsewhere. So that emphasizes the importance of training more doctors in autonomics. If you're getting better medical care, you're more likely to improve. So it's, I'm sure it's very, very frustrating for the vast majority of our patients. Over 90% of our patient community is not being seen at one of these autonomic disorders specialty sites. And they just physically can't see the millions of us that exist, right? There's only like 6 or 7 big autonomic labs, and most of them have only 1 or 2 doctors working there. So there's no way they can see the tens of millions of patients that have this. So we really, really need to focus on training other doctors and increasing their skill level so they can do a better job treating us. Comorbidities in POTS is a big deal. Almost everyone with POTS, 83%, have 1 or more comorbid diagnoses. That's just other conditions you're diagnosed with. Many patients have multiple comorbidities, and this really emphasizes the need for clinicians to learn what the comorbidities are in POTS, how to screen for them, and they need to understand how to treat them, because some of these comorbidities have different treatment approaches than POTS. So these were just the most common comorbidities represented. And there's a much longer list that's actually in the manuscript. When Kate is presenting, I'm going to type a bunch of the manuscript links into the chat so people can just read the manuscript directly if they haven't seen it already. This was a more recent abstract, I think in 2020, presented by Juliette Hall, who is one of Kate's colleagues at the University of Calgary, is getting into POTS research. And Juliette looked at the use of salt and electrolytes in POTS patients, and what percentage of us are using salt or electrolyte supplements, and what percentage of us are using both. So what she had found, and also whether our patients thought that these were helpful or not, right? So patients, a pretty small percentage said dietary salt intake improved their symptoms a lot. So we hear doctors putting so much emphasis on this, but a pretty small percentage of patients said, this really helped me a lot. A majority said that it helped them a little bit. And, about 30% said it didn't really do anything for them. When we interpret this, we don't know if the people who said there was no change at all, we don't know if they were taking the right amount or how long they tried it for, what other medications they might have been on. So we kind of literally have to take the salt data with a grain of salt. Patients using salt and electrolyte treatments. So that would be things like Vitacium or Normalite or other kinds of capsules that have various electrolytes in them. So these, most patients are doing both. They're taking salt plus an electrolyte supplement. That's nearly 60% of POTS patients. And then about 30% are only doing dietary salt. And then a very, very small percentage are just doing the electrolyte supplements alone. I do want to say for patients who are struggling economically, I don't think you have to feel bad if you can't afford the supplements. Some of them can be very expensive, right? So your body doesn't care. Sodium is sodium, and your body can absorb it from the cheap stuff just as well as from the expensive stuff. So if you're struggling financially, don't sort of feel guilty like, oh, I'm not doing enough because I'm not buying these expensive supplements. The supplements can be very helpful if you can afford them, but don't feel bad about it. You can still get the right amount of sodium that your body needs just through dietary salt. So I think people were basically saying they would stick to this more often if it was helping them, which kind of makes sense. If it's not helping you, you'd be less likely to stick with it. And so by age group, Juliette actually found that the younger kids were more likely to be using salt or electrolyte supplements. And the ratio is pretty much the same between male and female patients in terms of usage, but the younger kids a little bit more. And that could be because the pediatric doctors are less likely to prescribe medication. There's more of an emphasis on the non-pharma stuff for the kids. So that's why you might see more kids using the salt, because it's really all that was offered to them. So with that, I'm going to pass it over to Kate. I know I talked probably going to end up going a little bit beyond an hour here, but we did have a lot of stuff we wanted to share. So I'll turn off my camera and let Kate to present her probably much more organized presentation than mine.
Thanks so much, Lauren, for that great overview of all the work that has gone into the POTS survey thus far. So I will just share my screen here and start on my slides. So the slides that I'll be presenting now are the slides from the 3 manuscripts that we've published after the initial manuscript that Lauren shared. So the first manuscript that I'll be talking about is one looking at the employment and economic impacts of POTS. And I believe Lauren will put the link in the chat. So this is an open access paper, and you'll be able to read the entire paper if that is interesting to you. So in this survey, we only looked at participants who were age 18 and older. And we found that 48% of participants were employed. So less than half were employed in the 3 months before the survey. 67% of participants said that they would work more hours, but they were not able to due to their POTS symptoms. 82%, so a large majority of participants have had to call in sick due to POTS. Probably not surprising. Obviously, POTS symptoms are very debilitating. And 74% were unable to work for a period of 1 week or longer due to their POTS symptoms. 21% of participants had even lost a job due to their POTS symptoms, and 72% of participants actually had to modify their job due to POTS. So this is just showing here that 55% of participants had workplace modifications, 74% had to reduce their schedule, and 67% had to modify their job in other ways in order to continue working. In addition to asking questions about employment, we also ask questions about lost income. So again, the majority, 71% of participants had lost income in the 12 months prior to the survey due to POTS. And 36% had lost over $10,000 or more US due to their POTS symptoms. So that's sort of quite a bit of money to be losing due to the effects of POTS. Additionally, we asked about spouse and caregiver income loss. So if you patients had like a spouse or caregiver that had to take time off work or who had left their job to care for the person who has POTS, and 28% of participants indicated they did have a spouse or caregiver who had lost income. And in this case, we had 9% who had lost more than $10,000 US due to being a caregiver for someone with POTS. So not just the POTS patient being impacted economically, but also the people around the POTS patient supporting them have also had economic challenges. We also asked about disability benefits. So 34% of participants had applied for government disability benefits, and 12% had applied for private disability benefits. And that's just shown here in this figure. And then we had about 64% who had success with their government application, and then 74% who had had success with their private application. So that was just a very quick overview of the economic data. But again, the paper is available for you to read, and there is more detail included there. But just to quickly summarize, less than half of participants were employed at the time of the survey. Participants experienced challenges with employment, missing time due to work, losing their job in some cases, as well as having to modify their job. Most participants had lost income due to POTS. Job modifications may also help patients continue working. And despite the significant employment and financial impacts that we found in this survey, less than half had applied for government or private benefits. So switching gears now to sex differences in POTS. So this was another manuscript that we published. And again, this will be in the chat. It's an open access paper that everyone can read. And so this one is looking at males and females with POTS. So we know that the majority of patients with POTS are females, and we wanted to look at differences between males and females in this cohort. So as I mentioned, 96% of participants in this survey were female. This is consistent with our other findings in POTS that most patients are female. As Lauren mentioned earlier, the most common age of onset was 14, and more male participants indicated that their POTS onset happened within 3 months of a specific event. So patients were asked, like, did you have an infection or an accident or some sort of circumstance that led to the onset of your POTS symptoms? And more male participants indicated this was true for them. For diagnostic journey, so patients were asked questions like, were you misdiagnosed? Were you ever told that your POTS was psychological? Were you ever told that your POTS was all in your head? Sort of, unfortunately, this is very common for both male and female patients. So over 70% of males and females were misdiagnosed. Like over 70% of males and females were told it was psychological, and over 60% of males and females were told it was just all in their head. But female participants were significantly more likely to be told their POTS was just all in their head compared to male patients, which obviously shows that there is a bias and maybe some sex discrimination going on when patients are presenting with POTS-like symptoms. In terms of diagnostic delay, so again, the diagnostic delay is very long for both male and female participants. So this is not to say that it is not significantly long for male patients, but we did find the diagnostic delay was actually 2 years longer almost in female patients compared to males. And this is in a disorder where it primarily affects females. So even in that type of circumstance, the female patients are really just waiting quite a bit longer for their POTS diagnosis. But again, here you can see that the male participants were still waiting about 2.5 years. So they also have a very significant wait, but it just is, almost 2 years longer than that in the female participants. In terms of emergency department visits, so before diagnosis, a similar proportion of female and male participants attended the emergency department for their POTS symptoms. But after diagnosis, more females actually were still attending the emergency department for their POTS symptoms. So this might indicate that patients are not getting an adequate level of care or have unmet care needs that are requiring them to attend the emergency department for POTS. And then both before and after diagnosis, female participants were attending the emergency department more frequently. So before diagnosis, it was about 6.5 times that they had been to the emergency department. Similar before and after, but only about 5 in male participants. So those female participants were attending more frequently. What about symptoms? So most symptoms were more common in female participants compared to males. So again, these POTS symptoms were very common in both groups, but they were significantly higher in female patients. So things like lightheadedness, headaches, nausea, chest pain, shortness of breath, blurry vision, they were all significantly more common in the female patients. And similarly with comorbidities. So most comorbidities were more common in female patients. Neuropathy was not different. A similar proportion of females and males reported neuropathy, but comorbidities like migraines, IBS, EDS, autoimmune disorders were all significantly more common in female patients. What about social impacts? So again, this was a very comprehensive survey, so it did provide the opportunity to ask about many different things. So more female patients had lost a friend or lost a family relationship due to POTS compared to male participants. So female patients were reporting more impacts. And again, it's not to discount the impacts that male patients experienced, but we did see that it just was more common in the female participants. And quality of life. So the RAN36 is a quality of life tool that we use to measure health-related quality of life. So if you have a bigger number, it means that your quality of life is better. And if you have a smaller number, it means that your quality of life is worse. So in terms of physical health here, as well as general health, you can see that the female participants have a smaller number. So it means that their quality of life was actually worse. But for the mental health domain, the quality of life was actually similar in both groups. So female participants were actually reporting more quality of life impacts than male participants in this survey. So again, this is just sort of a whirlwind overview of these papers, but just to conclude on the sex differences paper, female participants did experience a longer diagnostic delay than males. More female participants attended the emergency department after diagnosis. More females than males reported common POTS symptoms, lightheadedness, nausea, symptoms such as that. Females also reported lower physical and overall health-related quality of life. And obviously, improving awareness of POTS may help us to reduce diagnostic delays and improve care for all POTS patients. So now we'll move on to the third manuscript that I'm planning to talk about, and that is our manuscript looking at POTS and pregnancy. So obviously, the majority of POTS patients are female, and they're most often a bit younger. So pregnancy is sort of an important topic to consider when considering the POTS patient population. So within the survey, there are about 3,600 patients who had reported they've been pregnant at least one time. Most participants were white and they lived in the US. And the mean number of pregnancies for these participants was 2.7. So looking at POTS symptoms in pregnancy. So this was one of the sort of big questions that the survey was wanting to look at, because there is a lot of different data that's been published, usually with smaller sample sizes with varying results. But what we were able to show here, these are the 3 trimesters of pregnancy. So T1 is the first trimester, T2 is the second trimester, and T3 is the third trimester. In the first trimester here, 63% had worse symptoms compared to before pregnancy. And then in the third trimester, 59% had worse symptoms compared to before pregnancy. In the second trimester, it seems like there was a little bit of a reprieve where only about 48% had worse symptoms. But overall, this is showing us that generally most participants are having worse POTS symptoms when they're pregnant compared to when they're not pregnant. And this was in a large group of thousands of patients. Looking at multiple pregnancies, meaning subsequent pregnancies, not twins or triplets, but if you were pregnant once and then you were pregnant again, in this case, 53% reported that their symptoms were worse with the subsequent pregnancies compared to the initial pregnancy. And then looking at the postpartum period, so this is the 3 months after giving birth, 59% of participants were still having worse POTS symptoms. So generally overall, most of this group was having worsening symptoms related to pregnancy. Another interesting finding that we found in this data was that participants' symptoms in the first trimester could predict how they would do throughout the course of pregnancy. So this is looking at if you were better in the first trimester, what happened to your symptoms in the second and third trimester. So here in the top, of the participants who were better in the first trimester, 77% were also better in the second trimester, and then 63% were also better in the third trimester. So if you have better POTS symptoms in your first trimester, you might be more likely to have better POTS symptoms throughout pregnancy. Now, obviously, this is not true for everyone, but it's was shown to be the majority of people in our survey. It's not as clear when we're looking at similar symptoms. So patients who had similar POTS symptoms in their first trimester, 46% had similar in their second trimester, but 37% got worse. And then of those who had similar POTS symptoms in their first trimester, 36% had similar symptoms in their third trimester, but 53% got worse. So it, as I mentioned, not very clear there. However, when we look at worsening symptoms, we can see that that trend sort of appears again. So if you had worse symptoms in your first trimester, 62% had worse symptoms in their second trimester, and then 68% continue to have worsening symptoms in their third trimester. Looking at POTS from pregnancy, so some participants reported that they actually developed POTS initially after pregnancy. And overall, this was 289 or 3.2% of the group who reported this. 38.1% reported that their POTS was triggered by something, but it wasn't pregnancy. And then 58.7% reported that they didn't have a trigger for their POTS. So it is a small group of participants, but it is definitely something that's been reported to have an initial POTS onset, with pregnancy being the inciting event. We also wanted to look at the role of other medical conditions. So we know about 25% of participants reported Ehlers-Danlos syndrome, and 17% of participants reported an autoimmune disease. So we wanted to look and see, are participants with these conditions having different pregnancy experiences than those who do not have these conditions? And of this group, looking all together, 6% had both EDS and an autoimmune disorder, 20% had EDS but no autoimmune disorder, 12% had an autoimmune disorder but no EDS, and then 63% didn't have EDS or an autoimmune disorder. But again, all of these participants did have POTS. So looking at symptoms, so again, here we have the trimesters of pregnancy and whether or not your symptoms were worse. So there were no differences. So a similar proportion of patients with and without EDS and autoimmune disorders had worsening symptoms during pregnancy. But when we look at the number of pregnancy losses, we can see that in POTS and EDS here. So we have pregnancies, live births, and then pregnancy losses. We can see that the pregnancy losses were actually significantly more common in the group with POTS and EDS. And then when we look at POTS and autoimmune over here, so again, similarly, pregnancies, live births, and pregnancy losses, we can see that actually the number of pregnancies was higher in patients with autoimmune disorders, but so was the number of pregnancy losses. So definitely the comorbidities of EDS and AI may, or autoimmune diseases may play roles in pregnancy experience in this group. So just to summarize this here, so most participants did experience a worsening of POTS symptoms during pregnancy, and this was in a very large group that was much larger than the previously published data. Symptoms during the first trimester of pregnancy may predict symptoms during the rest of pregnancy. So again, people who were better in the first trimester were most likely to continue to be better. People who were worse in the first trimester were most likely to continue being worse. Again, not the case for everyone, but it is something that we saw. Some participants did experience an initial POTS onset triggered by their pregnancy, and other medical conditions like EDS and autoimmune diseases may also impact pregnancy. And just to conclude on here, obviously we didn't ask about everything related to pregnancy, so more research is required to fully understand the impacts. So there's just one more short public publication that I did want to mention before I turn things back to Lauren. So this was a paper that was actually led by Juliet Hall, who was an undergraduate student in Dr. Raj's lab and is now a medical student in Calgary. And it was looking at healthcare experiences in the US compared to Canada. So most participants in the survey were from the US, but we did also have international representation, as Lauren mentioned. So in this specific analysis, we had about 5,700 participants, 96% from the USA and 4% from Canada. So Juliet was actually able to show that Canadian patients saw more doctors before diagnosis, had a longer diagnostic delay, were more likely to suggest POTS to their doctor before their doctor brought up POTS, and were also more likely to be told that their illness was psychological. So this is, again, not to discount the diagnostic experiences of other patients, especially in the US. We know the diagnostic delay is long. We know that physician recognition of POTS is not great, but Canadian patients just had even worse experiences with diagnosis. And so this is sort of important to highlight that, you know, our physician education and training in Canada really could be improved to help patients with POTS and their diagnostic experiences in Canada. So just a quick concluding slide. I obviously would like to acknowledge Lauren, Dysautonomia International for all of their amazing support, as well as all of the researchers who've helped me with my research throughout my graduate school. And then obviously all of the patients and the survey participants who were willing to take the time to complete this very comprehensive survey to help us understand more about POTS. So I will turn it back to Lauren to continue the presentation.
Okay, give me a second. I was just answering somebody's question.
Oh, okay. Sorry about that.
It's okay. Multitasking over here. Okay, I'm back. So just a couple more slides. I know you guys are probably sick of my slides by now, but just a few extra little nuggets here. Okay, so I did want to talk about the impact of this, right? A lot of times in academia, researchers kind of poo-poo surveys as like, oh, that's not real research, right? And of course, it's very different than a tissue biopsy study where we're like taking brain samples from POTS patients, right? It's very different to do a survey. But surveys can have massive impacts on the way that your patient community is treated, the way that your advocacy works, the way that your clinician education works. So I just want to highlight some of the cool outcomes that happen because of this survey, things that we never even expected when we designed the survey. So as I mentioned earlier, our manuscripts have been cited over 300 times. So that's pretty cool to have that many citations. For the first publication only came out in 2019. So we would expect those citation numbers to keep going up. That means other researchers are relying on this survey data in articles that they are writing. And so the diagnostic delay data, we have used that to successfully advocate for increased clinician education. Like in the past, we would go to, let me just pick an example. We would go to like University of Wisconsin and say, hey, we want to do a physician education course with you on POTS and other forms of dysautonomia. And they'd be like, oh, that's rare. Nobody really sees that. Like they would kind of be dismissive about it, right? But now we have this diagnostic delay data and we're like, look at this. Like people are suffering for years with no diagnosis. And POTS is actually easy to diagnose once you know how to look for it. So we've used that data to get more physician education courses going. People have been really receptive once we frame it as we need to reduce these diagnostic delays. And then suddenly there's like, oh, okay, we can help with that. And they're more interested in doing courses. The economic data, we use this in our federal advocacy to push for policy changes that benefit people with POTS and other forms of dysautonomia and other infection-associated chronic conditions. So not everyone with POTS has a post-infectious onset, but many people do. So we've aligned recently with other organizations that serve people with infection-associated chronic conditions like long COVID and ME/CFS. Some of the MCAS patients are post-infectious. So, that economic data has real impact when you're meeting with federal officials and you're saying like, we had data, I'm not sure, Kate, I'm not sure if we actually covered this tonight, but we had data on Social Security impacts and people who are on government benefits because of their POTS symptoms is an enormous number of people. And it costs the government a lot of money. So we are using that economic data to make policy arguments. This study has actually encouraged some pharma companies to invest in POTS research, which is really exciting. Everybody thinks pharma is big, bad pharma, right? Well, yeah, some pharma is awful, but really, if you look at diseases that have a lot of effective treatment options, it's because those disease communities got pharma to invest billions of dollars into studying and understanding their disease and developing more effective treatments. So we've just started to get pharma interest. And in part, they're telling us that, they're very interested in the data and they're using the data from that survey to actually convince their investors that there's this big unmet need in our patient community. So then, I skipped a slide. We broadened our understanding of POTS symptoms that were not previously discussed in the literature, like the small fiber sensory neuropathy and some other things. We've used this data to support the need for more research on the role of the comorbidities, MCAS, EDS, Ehlers-Danlos, chronic fatigue, all these sort of overlapping syndromes, autoimmunity. And that before Dysautonomia International existed, I really don't think there was a big conversation happening on that in the POTS world. It was like, oh, POTS is POTS and it's benign. And, but I think more and more people are realizing that these overlapping conditions need to be studied together. So some of the data from our study was used by the National Institutes of Health, was used by Vanderbilt to advocate for themselves to get grant funding to study glucose abnormalities and gut peptide problems in POTS. So that was kind of cool to see other researchers taking this data and saying, oh, we want to do more in-depth research on this clinically at Vanderbilt. And so they cited our data to help get themselves an NIH grant, which we fully support. We actually funded their initial glucose metabolism study that got their sort of their seed study that got them a little bit of data that they could take to NIH to say we need more to do a deeper study. It's provided an opportunity for young researchers like Kate and Juliet and others to gain POTS research experience. As a field, we need to recruit more people into this field and catch them while they're young and still in medical school or still in grad school. So that's kind of cool. This study documented for the first time that many POTS patients do not grow out of it, which was definitely the myth when we first started Dysautonomia International. Everyone grows out of it. And there's still some doctors who say that, but now we have some data showing, that's just not true for everyone. We have increased POTS awareness at every single time we've presented one of these research posters at a conference. There's been a lot of interaction with other doctors who are outside of the dysautonomia field, coming up to our posters and talking to us and really having that one-on-one educating doctors. And it feels really cool when you have like a total stranger come up to you and say, I have a few of these patients, I don't know what to do with them. And they come and they talk to you at your poster and then they leave, asking for more POTS educational materials for their office. So it's kind of neat to see that. We used the way we designed the Big POTS survey and what we learned about doing this kind of large cohort survey, we used that knowledge to create the long COVID dysautonomia survey with Stanford in 2021, which at the time it was published was one of the largest surveys on long COVID patients. And it found that 67% of long COVID patients have some form of dysautonomia, and other research showing most often it's presenting as POTS, but also orthostatic intolerance and some other types of dysautonomia in long COVID. Dr. Boris, who used to run the pediatric POTS program at Children's Hospital of Philadelphia, he loved the Big POTS survey so much that he actually said, hey, can I borrow your survey design and screen my pediatric POTS patients with it? And so myself and Dr. Raj said, sure. And we work with Dr. Boris on other research things, and he's on our board. And so he did that, and his publications are coming soon. Just yesterday, Dysautonomia International's board of directors authorized giving him some funding so he could make his journal articles open access so everyone could read them. So that'll be, hopefully in the next few months, that will appear in the literature and it will be open access. Also kind of important, the Big POTS survey is actually the largest study ever done on POTS to date. And I love that the biggest study on POTS was like designed by patients, with patients, for patients. I think it sets a cool precedent in the field that patients really should have a seat at the research table, to be part of those conversations, not just the recipients of, someone poking and prodding us and just studying us, but actually patients having a say in how studies happen. And so we have a follow-up survey that we have been working on, particularly Kate has been working on. And when that survey is ready to launch, we're gonna email it out to everyone who initially took the survey, everyone who's taken it to date. I think you will have to have taken it more than 6 months prior to our follow-up survey launch. And when we do that and we get the data back from the follow-up survey participants, that will be the largest and longest follow-up study in POTS to date. So one of the big deficits in POTS research is we have these one-off studies, like Mayo does a study looking at a subset of patients that were at the clinic in the past year, right? But nobody really follows patients for like 5-10 years to see like what's happening over time. Are they getting other diagnoses? Are they getting better? Are they getting worse? Do they find new treatments that worked? And so having that long-term follow-up survey is going to be the longest follow-up survey ever done in POTS research once we have it. It's called longitudinal research. So that will be neat. So how can you get involved in all of this? So you can take the survey if you haven't already taken it. I will share the link in the chat when I'm done yapping. But you can also, if you dig around a bit, it's on the Dysautonomia International website. There's a link to it in there, but we can, I'll share the bit.ly link. You can, if you've already taken this survey at any point in time, be on the lookout in your email for a follow-up survey. So importantly, if you took the survey in 2015, you might have a different email address by now, right? We know that especially college students change their email addresses when they graduate or drop out. So if you took the Big POTS survey previously and you know for a fact that your email has totally changed since then, you could email me. You could email info@dysautonomiainternational.org, and we will try to, we would need to know your name, your old email address, and your new email address. And we will try to make sure that the follow-up survey gets to as many people as possible. It's going to be hard to do that because there's like literally like 10,000 plus people in the study. But if you can be patient with us, and we'll try to get that, make sure that as many people get that as possible. And then let your friends and doctors know about the survey, particularly if they're doctors who see a lot of POTS patients. We want to get as many POTS patients in it as possible to really make sure that it reflects the broadest diversity of our patient community, different countries, different ages, different races, just making sure everyone has an opportunity to have their story told through this data. And then sharing the results of this survey to educate the public and medical professionals. A lot of the infographics that Dysautonomia International does on POTS come from the data from this survey. So making sure, helping get the word out about POTS is always a great way to sort of be involved in moving our community forward. And then last but not least, if you're able to, consider supporting Dysautonomia International's POTS Research Fund. I had mentioned that there was not any funding for this study to date, but we've, Dr. Raj and Kate and their whole team and a bunch of folks at Vanderbilt have put so much hard work into this that we actually do want to provide some funding to do more follow-up work, because there's actually so much data from the first round of the survey that still hasn't been published. So we figured if we put some funding into it, maybe we can get more statisticians and other people helping us get this data all published. So please consider donating if you're in a position to do that. So here's some really quick other POTS research updates that we think you guys might be interested in. So we got this information yesterday. If you follow national politics, you might have heard that the new NIH director was voted on by and confirmed by the Senate today. It's amazing that Congress gets anything done given all the partisanship there, but she had bipartisan support. And so before an NIH director or other agency head is confirmed by the Senate, senators are allowed to ask them questions, or allowed to ask the agency questions. So Dysautonomia International reached out to our contacts in Congress, in the Senate, and got the senators to ask the NIH some questions about what's going on with POTS research behind the scenes, stuff that is not normally publicly disclosed by NIH. They hold everything very close to the vest. And so what we found is we knew how many POTS studies had been funded, because that is public info, at least 2020 and prior. But what we were really interested in is how many applications they were getting that they were turning down. And so this, this is a shockingly small number of applications that are getting applied for, and even smaller that are getting funded, right? So, I mean, I think in fiscal year 2020, the NIH basically dropped everything and only funded COVID research because, the world was in crisis. So I think we can maybe give them a bit of a free pass for not funding too much POTS research that year at all. But we do really need to see these numbers going up. But this ratio, this 3 funded out of 17 applications, that's actually standard for National Heart, Lung, and Blood Institute, which is the sort of cardiology, pulmonology branch of NIH. They only fund about 18 to 20% of applications they receive. So that's of 17, that would be 3 or 4 studies. They did tell us that in fiscal year 2023, which is this year, that they have funded 6 POTS studies. We know what 2 of them are, and we are emailing all the POTS researchers we know to say, what else did you get funded this year that we haven't heard about yet? But the 2 big studies that we know of are, there's a long COVID POTS clinical trial that's funded by the NIH through the big RECOVER study, which is this billion-dollar long COVID study. And they're going to study IVIG and ivabradine in long COVID POTS. So even if you don't have long COVID POTS, that kind of data is hopefully going to be helpful to the whole POTS community, because if it works in long COVID POTS, then that justifies doing more research in non-COVID POTS as well. The other study is not specific to COVID. It is Dr. Vernino, who's on our board from UT Southwestern, got a very large grant to do a POTS like deep phenotyping study. And we love this, that he got funded, because we actually pitched this study to him and a couple of the other autonomic docs, doing, instead of like one study that just looks at small fiber neuropathy and one study that looks at hypovolemia and one study that looks at EDS, we needed a study that looks at all the things that we know to look for in a good size, like 100+ POTS patients, and really just deeply characterize how these comorbidities overlap, how they overlap with different symptom profiles, how their immune markers overlap and their genetic markers overlap. And so he got a pretty large grant to do that. It's a 5-year grant that starts this year. So that's, it doesn't feel so great to see that there's only a handful of studies being funded, but this progress, this going from 1 study a year to 6 studies this year, is entirely because of the hard work of Dysautonomia International advocates who have gone to Capitol Hill, who've written to the NIH, who've showed up at meetings, at congressional hearings, giving congressional briefings on the Hill. We're just sort of, you have to be persistent to make change in federal policy. And we've been blessed with an amazing army of parent and caregiver and doctor volunteers who help us do that. So NIH is now tracking POTS that has been reported on death certificates nationally. So when people hear this, I'm sure some people get really scared. Oh my God, we were told POTS isn't fatal. So this doesn't mean that POTS is fatal. This means that someone who had POTS died, and POTS, because they had POTS, was listed on their death certificate, right? So you have other non-fatal conditions, for example, an ear infection, right? So people who had an ear infection had ear infection listed on their death certificate. It doesn't mean that the ear infection is their cause of death. But this is pretty interesting. And so it has led to conversations with the NIH about doing a more intentional, like setting up an autopsy study in POTS, which will be hard because people with POTS usually don't pass away. They tend to be younger. And if they do pass away, it tends to be from other diseases or diseases, old age, or just complications of a surgery or a car accident or something like that. But we are working with NIH and some of the autonomic labs to try to set up a POTS autopsy study to learn things that you can't get samples from healthy people, right? You really can't take a brain sample from a living, healthy POTS patient, or a heart sample or something like that. So we're working on that. And then, oh, by the way, and this tracking of POTS was not happening before, I think this is 2019 when they started tracking it. And that happened because of our congressional advocacy. We pressed for this, for public listing of POTS research funding, to hold NIH accountable for their decisions. So next slide. I mentioned pharma earlier, but there are two particular studies I wanted to mention. Argenx is a European pharma company that has US operations, and they have a drug called efgartigimod. It's in commercials on TV now. If you're living in the US and you see commercials for Vyvgart, that's a myasthenia gravis approved drug, and it's sort of like a synthetic form of IVIG. And they're doing a pretty big study. It's actually not that big, but they did an initial study, phase 2, in long COVID POTS, right? And so, of course, we had a lot of conversations with them and said, we really want you to study this in everyone with immune-mediated POTS, people with POTS who have one or more abnormal immune biomarkers. And their answer was like, we're interested in doing that, but we're going to do long COVID POTS first. And from a scientific perspective, I understand why. People with long COVID POTS have more recent onset, so are probably more likely to respond to an immune modulating drug. And people with long COVID POTS all have the same trigger. They all had COVID. So they're doing that first. But the phase 2, we've heard the phase 2 went well, and that they're going to be launching a phase 3, which means when they do a larger group of their long COVID POTS patients. And so we continue to ask, are you going to study this in other POTS? And we're getting sort of like a wink and a nod, like, yes, we're going to get there, but nobody has formally said this publicly yet. But we will keep pushing for that. And then Amgen is the company that makes ivabradine, and they have funded some research on studying ivabradine in POTS. And we are trying to talk to them about actually trying to get an FDA approval for it, because right now a lot of patients are having a hard time getting their insurance companies to pay for ivabradine because it's not FDA approved for POTS, and it is more expensive than beta blockers. So that's been going on. There are several other pharma companies starting to do work in POTS. They have not publicly announced things yet, but we are sort of behind the scenes working with them and making sure they understand the needs of the patient community, and making sure that they're working with good POTS researchers who aren't going to design like stupid studies that don't work. We really want them to find the experts that we know are doing good work for these patients. And then there's data coming soon on a lot of kind of things in the hopper. Vascular malformations in POTS, particularly from Emory University. Dr. Alexis Cutchins has been doing some great research on that. There's a POTS IVIG pilot study that Dr. Vernino will be announcing the data from soon. There's a POTS plasmapheresis trial happening in Australia that we have funded. And the data on that, I'm hoping we might see early data on that next year. There are 2 different POTS low-dose naltrexone trials that we have funded, one in Europe and one in Canada. There's a POTS ivabradine versus propranolol trial. And why is that important, right? Because if we can show that the ivabradine works just as well as the propranolol or even better, then that helps people fight with their insurance companies and their doctors to get ivabradine, assuming the propranolol wasn't working enough for them, or because it's so much cheaper than ivabradine. Most doctors and most insurance companies would prefer the cheaper drug, but if it's not working very well, you want to have another option available. And there's also one POTS vagus nerve stim trial that we funded has already published out of Humanitas University in Italy, and the data looked really good. But there are 2 other trials we have funded, and the data is hopefully I keep waiting for it to come out. I think a lot of things got delayed because of COVID, because research just kind of shut down for a year or 2, but everybody seems to be back on track now and sort of moving forward. And so I'm really excited to see this data. I mentioned before the big NIH study. One of the things NIH is studying is long COVID POTS ivabradine. But there's also a study at Walter Reed Military Medical Center looking at long COVID POTS and long COVID IST, which is inappropriate sinus tachycardia. So there's 2 different ivabradine trials going on. I really hope that collectively, all this ivabradine data will hopefully make it easier for POTS patients to get access. So that's it. We can take a little Q&A. I know we went a half hour longer than planned. But here are just some helpful quick links if anyone wants. I'll leave those up. But Kate, if you want to join back on, maybe we can take a few questions. I know we've been trying to answer questions in the text, typing in when we can. But so let me see here. So there's I think I answered one question already in the chat, in the text, but someone asked, is the age of onset of POTS changing with the uptick in COVID cases? So I had typed an answer in the chat. Kate, I'm wondering if you guys are seeing a difference at Calgary in your POTS patients coming to the clinic there.
Yeah, it's a very interesting question. I think the idea is that there are some older patients with the long COVID POTS, and perhaps it is shifting the demographic. I think it would be quite interesting to look at the survey data now with more participants who've done the survey since COVID to see if that is shifting as well. But it does seem like, based on our sort of research and studies in Calgary, that there is an older age now. Yeah.
What we're seeing in our support groups is long COVID POTS tends to be more mature adults in their 30s and 40s getting new onset POTS. It tends to be more male, than more evenly distributed between males and females than the pre-COVID POTS population. And we're also seeing more racial and ethnic diversity. And I think that might actually just reflect who was most impacted by COVID, right? COVID was not really sex discriminating much, so kind of evenly dispersed. There is pediatric COVID and pediatric long COVID for sure, but the numbers seem very different than the adult onset. And a lot of more diverse people got COVID because they're working on the front lines, all the disparities in healthcare we have throughout the world. So I think it's really going to open up a new avenue of POTS research. I think it's so important to get more diverse people involved in POTS research, and not only as patients participating, but actually as researchers too. So we've really tried to support people in other countries who are doing POTS research. We need to explain. That actually flows very nicely into the next question. Someone asked, what countries are the ones that have the most developed research and or treatment of POTS? Well, I think Kate and I might have a little bias, but I would say probably the US has the most POTS researchers and clinicians that are really experts. But certainly Dr. Raj's lab at the University of Calgary, I mean, he's like the magic guru of POTS research. So I think Canada is doing pretty good on that front, except clinically, there are very few doctors in Canada who do POTS other than, a very small handful. So Kate, what are your thoughts on geographic POTS expertise?
Yeah, I think that's right. Like, the research in Canada is good, but the clinical care in Canada has a long way to go. I'm not sure.
We just need Kate and Juliet to become doctors and move to other provinces so they can open autonomic labs.
For sure.
Someone asked, this is interesting, will there be any study linking POTS to autism? there are significant overlaps between neurodivergence and EDS, and linking POTS to the risk of type 2 diabetes. So I think this is we could have a whole presentation on this question. What are your thoughts on the possible relationships between POTS and autism?
I think it's a really interesting concept. I don't know if I necessarily have specific expertise on that topic, but I think it's something that is worth exploring, I would say.
Yeah, there was a graduate student, I believe, and I apologize if she's listening and I'm misquoting her title, but I believe it was a grad student out west who was studying like sensory overload in POTS, like people who have just like really overstimulated sensory perception. And that has a strong relationship with autism, right? And she was finding this, I believe she actually had an autism question, and she found that autism comorbid diagnosis was actually twice as high in female POTS patients compared to male POTS patients, which is kind of the opposite of most autism research that points to it being more male predominant. So that was interesting. And of course, those of you who know Dr. Jessica Eccles out of University of Sussex, I was on a Zoom call with her yesterday. We were funding some of her research on cognitive impairment and brain fog in POTS, and she is super into trying to understand the relationship between EDS and neurodivergence and autonomic dysfunction as a big, like that's its own trifecta, you know? So she has some interesting data on that. She's actually going to do a webinar for us in early 2024 with some of the data on that. So maybe we can get her to touch on the neurodivergence autism question a little bit. Let's see. Somebody said, are you planning to collaborate with LATAM institutions to broaden the data? So I don't know what that means, but if you can type another question and tell us what LATAM stands for, we could answer that question. And apologies for not knowing what that is. Someone says, I can't remember if I took the survey or not. How can I tell if I took it? Oh, the perils of brain fog. We feel ya. So Kate, do we have a good answer on this? I think you had developed some questions to try to help people figure out if they took it.
I think they could email the Raj Lab at VUMC and we could confirm potentially.
Yeah, I don't know if that email off the top of my head. You could email info@dysautonomiainternational.org. We would need to know your full name and the email address you likely used when you took the survey. And we will get it to the Vanderbilt folks who actually have the real database. Just so everyone knows, that actual, like the patient information data is kept under lock and key at Vanderbilt. It's not used by Dysautonomia International or anyone else. The research data is, as standard in research practice, is de-identified, meaning that we have like someone's numbers, but we don't have like their social security number and their name and stuff like that. But there is someone who has like the master key at Vanderbilt that can look things up if needed. Will the slides be available after? Yes, we will make the slides available when the video is posted, which should be in a few weeks. Someone's asked, does Dysautonomia International ever have volunteer opportunities? Yes, we have over 400 volunteers. They are the lifeblood of this organization, even if we're all a little hypovolemic. So if you want to email info@dysautonomiainternational.org, we can connect you with our volunteer coordinator. Let's see. Oh, here's a good question we don't have an answer to, but we should totally talk about it. Is there any research on POTS and how it affects perimenopause? Are there any studies on POTS being cured post-menopause? I'm passing that one over to you.
Yes, I think this is so interesting and definitely something that needs to be studied for sure, because we know about changes in the menstrual cycle, changes in POTS symptoms, and the role of hormones, and whether or not that will change after menopause. I'm not aware of any specific research looking into this. I'm not sure if you are, Lauren, but I think it's definitely on the list of what we should be studying.
Yeah. The whole topic of sex hormones in POTS has literally not been done. The only study that really looked at gynecological sex hormone related things was actually Dr. Raj's study from years ago. And he found that women with POTS, who are the majority of diagnosed cases, that women with POTS were 5 times more likely to have estrogen dependent gynecological disorders. So that suggests that women with POTS might be at an increased chance of having like high estrogen levels, like high female sex hormones. There is also a case series from Dr. Boris when he was at Children's Hospital Philadelphia. CHOP has a gender transition clinic. And so they had some patients who were assigned female at birth who used testosterone hormones to transition to male in their, I think, like late adolescence. And these patients reported dramatic improvement in their POTS symptoms when they started testosterone. There's a lot of research outside of POTS on autoimmunity being associated with low male sex hormones. Even females have male sex hormones. And so there's, for example, there's data in Sjogren's, which has a lot of overlap with POTS, showing that women with Sjogren's have low levels of male sex hormones, like compared to what is normal for a woman. So when they supplement Sjogren's patients with testosterone precursors like DHEA, then their Sjogren's symptoms improved. So we want that kind of research done in POTS. The first thing would be, do people with POTS have abnormal levels of sex hormones, male or female? And then if the answer is yes, can correcting those hormone abnormalities improve POTS symptoms? So that's not directly answering the perimenopause question, but I'm 45. I have not had to start thinking about menopause officially yet, but I have, been doing dysautonomia advocacy work since almost like 13 years now. So I have friends that, we were young and not thinking about menopause when we got first involved in advocacy. And now we're all reaching our 40s and 50s going, I wonder what's going on with this menopause stuff. So I literally just like last week posted on the big POTS group on Facebook, like, let's talk about menopause, and kind of getting women to share their stories and their experiences. And so I think that conversation needs to happen to drive the research. We really want the research to reflect what the patient community knowledge already is, so chat about it on support groups, get the conversation going. Let's see. Okay, moving on to another, we'll probably just do like 2 more. Are there any resources regarding POTS and glucose? And this patient says, love from Australia. So love right back to you. Thank you for, I don't know what time in the morning or night it is there, but it is probably very different from Kate in Calgary. Kate, do you know about the Vanderbilt glucose stuff, or do you want me to?
A little bit, but I think if you're able to answer, that would be great.
Okay, sure. So Dr. Shabao, who works pretty closely with Dr. Raj because he used to be colleagues with her at Vanderbilt, she did a study that Dysautonomia International funded the pilot study. And she found that people with POTS, when they intake glucose, when they do like a glucose tolerance test, they have an abnormal response to glucose. Their insulin goes up, as it should. Insulin is supposed to go up to lower glucose levels, but their insulin goes up and it doesn't lower their glucose levels. So that suggests that people with POTS have insulin resistance in their pancreas. She also found that people with POTS have too much of a certain gut peptide, and this gut peptide is actually synthesized by these cells in your gut that are actually driven by your autonomic nervous system. So your autonomic nervous system is basically making too much of this gut peptide that's kind of messing up your glucose regulation. And what was really interesting is that she found when POTS patients had a certain amount of glucose intake, their tachycardia worsened, their orthostatic symptoms worsened, and they just generally felt worse. So a normal person is eating carbohydrates throughout the day, right? And so for years, we had it on our website a recommendation for patients to try a low carb diet. And we kind of disclose, like, this isn't based on research, it's just based on lots of patient anecdote. We got yelled at by so many doctors for saying that, right? Because they're like, oh, there's no proof. And we're like, well, when you talk to 100,000 patients for 10 years, and a lot of them tell you the same thing, that's an anecdote that's worth talking about. So sure enough, that's what Dr. Shabal's research has shown, that a majority of people with POTS have a pretty abnormal response to carbohydrates. And so now she, as a big, serious POTS researcher, is saying, maybe we should try low carb diets for POTS patients. And I don't think anyone should take it to the extreme, right? But just thinking about your intake of carbohydrates and trying to notice, does it change my symptoms if I eat a lower carb diet? Related to that, we've also funded research at University of California, San Diego. Dr. Taylor Doherty and Dr. Pam Taub. Dr. Doherty is an immunologist who's interested in POTS, and Dr. Taub is a cardiologist who's very interested in cardiometabolic health. And so what they're studying is time-restricted eating. So this is when, in their study, they're not changing the patient's diet or medications or anything, but they're telling POTS patients, if you enroll in the study, you eat in a 10-hour window during the day, your normal food, whatever you want to eat. And then outside of that 10-hour window, you fast for 14 hours, but you have to stay very, very hydrated. You're allowed to hydrate in that 14-hour window. You're not completely depriving yourself. You just can't eat food. And what they found is that actually is really helping a lot of the patients. And so I know when people hear this, some of them go, oh, that's like woo, that's not real treatment, right? But the cool thing about their study is they're looking at immune biomarkers and mitochondrial markers and metabolic markers to figure out what the symptom improvement is actually caused by, what the biological mechanism is. So that's also related to glucose regulation and sort of timing of your food and stuff. I think there's a lot of research that can be done in dietary interventions in POTS that just, we do it as patients. We try this, we try that, try gluten-free, try dairy-free, try FODMAP, but we really are just guessing, right? So hopefully having more dietary research will help us target it a little bit better. Let's see. Here's the question. Are there problems with infertility in POTS? So we didn't see that in our data. I don't know that anyone has super carefully studied that question, but it didn't really seem, it seemed like a pretty normal rate of births, right? In the pregnancy study.
I think so. Like, I'm not sure if we can totally conclude that from the data. But yeah, I think something to study in the future.
Yeah, definitely on the list of sex hormone study and not just sex hormone, but kind of gynecological health questions. Here's a question. Any updates on the new ear stat device? So that is the webinar we are presenting on November 15th. We hope everyone will join us. The founder of STAT, who is a research guy, and he started this company because his dad has a severe older person form of dysautonomia and is a fainter. And he wanted to develop a device that could help his own dad. So I think that's like super sweet, but he's also a great scientist and engineer. So we're going to talk about that on November 15th. Let's see. What are the biggest things you see that improve POTS symptoms? I'm going to ask that to Kate.
I think that's a tricky question because can be so different for each person.
Yeah.
I think, if you can find like medications that are helpful, that's great. If you can do some of the non-pharmacological things, increase salt and water, compression garments, exercise for some patients. But I'm not sure, there isn't one, do this thing and you'll get better. So I'm not sure, Lauren, if you have like a different answer, but I would say like it's just really a lot of like learning how to manage it and trying different things and then coming up with what is working for you specifically, I guess I would say.
Yeah, I think it needs to be very individualized. But if you're newly diagnosed or just trying to learn the ropes of this, maybe you've lived with it for a long time and just found out you have it, I would think the most important fundamentals that most patients, and I say most because it's not everyone, right? It is very much individualized, but most patients are benefiting from increasing their salt and fluid intake. So the doctors usually recommend, we're not doctors, Kate and I are like, we're only doctors on Facebook. We're not doctors in real life yet. Kate's going to be a doctor, but she's not there yet. So, but so I just want to be careful and not giving like specific medical advice. But most experts who are physicians would recommend like 2 to 3 liters of hydrating fluids a day, 8 to 10 grams of sodium per day, getting regular exercise, which is probably the hardest thing to know, like where to start and how to do it without making yourself feel worse. Medical compression stockings, which Kate did this awesome study on. You want to tell us this quick scoop on the compression?
Yeah. So the biggest thing for compression garments is that you need to have compression that is squishing your abdomen and upper legs. So in our study, we found that compression socks that only go to your knee actually have like a minimal to no benefit for heart rate and symptom control. So Spanx, shorts, waist-high compression tights are what you should be looking for if you're hoping to reduce your heart rate and improve your symptoms. That's the very quick summary.
Yes, squish the right places.
Yes.
It's a scientific term. And then of course, in addition to those non-pharma approaches, which are sort of like the POTS fundamentals, many people do need and benefit from different medications. And the most commonly prescribed medications for POTS are beta blockers, midodrine, fludrocortisone, less people, but possibly more helpful to get ivabradine or mestinon, which is called pyridostigmine. But it's kind of harder to find a doctor who's comfortable prescribing that because mestinon is a pretty like it's a serious drug. It's not like an Advil, or it's not even like a beta blocker. Like usually a neurologist is going to prescribe that. A lot of other doctors are a little bit afraid of that drug. So here's a good question. Why is there no support groups for Saskatchewan? Can we start one? I think there is one for Saskatchewan that might not be listed on our website yet, but we absolutely can start one. And I just want to say broader, if you live in a part of the world where we do not have a support group yet, we would love to hear from you if you want to help us start a support group in your region or country. We have support groups in all 50 US states, all over Canada, and 60 other countries, but there's big chunks of the world where we don't have support groups yet. So if you're in an area that doesn't have a Dysautonomia International support group, feel free to reach out to info@dysautonomiainternational.org. We would love to work with you to start one. I think probably should just be our last question because there's like a gazillion questions. And I apologize to anyone if we didn't get to your question. It's not because we don't care. It's just because there's just so many questions. Let's see. Is there any data on POTS and recurrent pericarditis? So I would say there probably isn't any data on that. However, I have POTS and recurrent pericarditis. So at least there's one other patient that has it. I have recurrent pericarditis as a result of my autoimmune disease that is probably also the cause of my POTS. I have Sjogren's syndrome, and recurrent pericarditis is sometimes referred to as recurrent autoimmune pericarditis. It's most often seen in lupus, scleroderma, rheumatoid arthritis, and Sjogren's. So if you have recurrent pericarditis, I would get a careful workup for different autoimmune conditions and try to find a cardiologist that actually has real pericarditis expertise, because it's kind of it can be like a sort of a niche within cardiology. You want someone who really knows what they're doing with it. There is actually an immune modulating drug for recurrent pericarditis now. And I reached out to the company and asked them if they would do a trial specifically on dysautonomia patients who have recurrent pericarditis, but they were like, what's that? So it's a little work to do educating there. Okay, I think I'll give you one more question for you, Kate. Let's see. Oh, Arena posted the link. She posted the Saskatchewan link, so I'm just gonna say thanks. And her link for Saskatchewan will be available to everyone. There. Let's see. What about pre-COVID POTS patients? Please help us. So I hear this sentiment from patients, and it's like, we are helping everyone with POTS. We are doing everything we can as an organization, and so are the researchers and clinicians. I do feel like there are some people who feel like, oh, those COVID patients got it more recently, we shouldn't focus on them. Like, when you were newly diagnosed, you probably wanted someone to help you right away too, you know? So we have to do both. We can't just do long COVID. We can't just do pre-COVID. Like, we all need to realize we're in the same boat. And if we all row together in the same direction, we're going to get where we need to go a lot faster. But there's a ton, like the vast majority of the work that Dysautonomia International does has nothing to do with COVID. And that's because we've existed for many years before COVID. So I guess that wasn't really a question. That was more of a statement on my part, but it was a question from someone in the chat. All right. Any closing thoughts from the brilliant Kate?
I guess just thanks everyone for attending, and stay tuned if you have done the first survey for an email inviting you to do the follow-up.
Yes. And we will email everyone this recording and the slides in a week or two, and we can put some other helpful links in that email. So anything that people might have missed today. So, all right, thanks all. Have a good night or evening, wherever you may be.